Welcome to Eat Kale and Cupcakes. I'm Laura Cipullo, registered dietitian, amongst other things.
And I'm Dr. Shannon Herbert, registered dietitian, amongst other things.
And today we have with us our friend and colleague, Dr. Risa Fridy. Hi, Risa.
Hello, thanks for having me.
Thanks for joining us. What are we talking about today?
Well, we are talking about a lot of things, but I am an adolescent medicine physician. And for our listeners, I work very closely with Laura and Shannon and dietitians a lot. So I'm here to explain to you what I do and all about the patients I see and how I collaborate with other healthcare providers in my field and sort of share some light on anything that Laura and Shannon want to know.
Yeah, and just so for our listeners or viewers to know, Dr. Friday and myself met a long time ago. Well, I believe you were a resident or perhaps a fellow.
Fellow,
We
yep.
lived in the same apartment building in New York City. And so it's just a small world. And
Yep.
we realized we both specialized in eating disorders, amongst other things. And so the relationship began.
Yes, we have known each other for a long time.
Yeah, super cool. It's really nice to collaborate with people that and have a relationship with so that you can collaborate on a regular basis and know their values.
Yeah, absolutely.
Yeah.
That is important.
So tell us a little bit about what is adolescent medicine and how does that differ from being a pediatrician? Because we will want to get into how does adolescent medicine and nutrition work, and what is it that you're seeing in the culture right now of raising an adolescent?
Yeah. Okay, so let me explain a little bit about what adolescent medicine is because I think that it's not really well known. I think it's not really well understood, even if people have heard of it. But the number of times someone has asked what I do or what kind of physician are you? And I say, I'm an adolescent and young adult physician. And they're like, what's that? So it's really a very an unfamiliar field to a lot of people, which is disappointing because it is, in my opinion, obviously biased, such an important field. So I am a pediatrician by training. I am a board certified pediatrician. Many, but not all, adolescent medicine physicians are. Adolescent medicine is a board certified specialty. So after my pediatrics residency for 3 years, I then did 3 more years of a fellowship in adolescent medicine. Any physician theoretically could go into adolescent medicine, but you already have to be boarded in a general specialty. So you either have to be a pediatrician, an internist, or a family medicine physician. So it is a subspecialty.
Okay.
So a lot of years, which, sounds kind of crazy, but I think adolescents and young adults are so incredibly complicated. And we wear a lot of hats within the field, and a lot of us in the field end up sort of subspecializing even further. So in our training, in our 3 years, I would say, here's kind of the rainbow of subject matters that we sort of learn to specialize in. We work a lot with nutritional and metabolic health and specifically eating disorders because eating disorders really are quite rampant in the adolescent and young adult population while they cross the spectrum of ages. Unfortunately, that is the hub, I would say. So we do a lot of work with nutrition, but then also metabolic issues across the spectrum, all different types of eating disorders and all different types of metabolic issues. We do a lot of sexual and reproductive health. So everything you can think of from general primary sexual and reproductive health care, a lot of puberty work. So whether it's early puberty, delayed puberty, abnormal puberty, bothersome or painful symptoms of puberty, and everything in between. And then also sexual health. So sexually transmitted infections, screening and treatment. We do contraception. I personally put in intrauterine devices, IUDs, and subdermal implants in the arm for birth control. So all along the spectrum of sexual and reproductive health, we do pap smears, we do it all, if a patient's old enough. And then we also do a lot of mental health. We are not psychiatrists. We are not therapists, but because of the age group that we work with, we have a lot of training. So during fellowship, we do a lot of overlap with the therapists and psychiatrists in the hospital, and we learn a lot from them. And so we really incorporate a lot of modalities into our work. And generally, I would say adolescent medicine physicians are highly sort of psychiatrically aware, because I think there's something that makes you interested in this population, that you tend to have a really good understanding of the mental health of this age group. So it really is incorporated into a lot that we do. And more. I mean, there's a lot more nuance to it, but I would say those are like the top 3 areas. And for really any patient that walks through our door, I think one of the things that makes us really specialized is that you might come in for, I don't know, like a wart on your finger, and we will end up doing a whole psychosocial exam and history around your sexual health, around your mental health, around your, nutritional health, and sort of uncover things. So most patients don't walk in and out the door with the same list of concerns, because we really unroof a lot of things and get into it.
Yeah, and I think that's so important, because there are so many clients or just adolescents, I think that parents or therapists, maybe they're not aware of questions to ask, right, related to psychiatric well-being, or especially to eating disorders, especially in this culture of looks maxing. I'm really thinking about the boys that, I really feel there needs to be a specialist and almost a better list available to parents and or practitioners, maybe even the pediatrician, of like, what do I ask and look for, to see, is this individual struggling with body image and how is this affecting them? Or even perhaps are they, constipated, and it's not about increasing fiber. It's really because the kid is so strung out, right, from the stress of the culture or for looking a certain way, and therefore they are, super tense in their physical body, and maybe actually need to be referred for pelvic floor therapy rather than increase their fiber, right? So it's like there's so many nuances. So I do think that the specialty is so necessary, and I wish more individuals were aware of seeing an adolescent specialist. And again, it depends on the kid. I actually have one kid that sees an adolescent specialist, right? And then I have one kid that doesn't, that sees the regular pediatrician. Mm-hmm. So, and any advice for parents on how to identify if you need an adolescent specialist, or maybe what would be helpful in identifying, for them if their child would benefit from seeing someone, like to switch over from like at what age from a pediatrician to the adolescent medicine person, and how it could potentially be beneficial for that individual or maybe the family.
I was going to say, like, the age range that you're typically working with and seeing, and like what falls under the purview of like adolescent medicine.
Absolutely. It's a great question. Okay. So first, just to answer the age range, I wouldn't say, so I'm in private practice, which is definitely a little bit different because we have a little less rules to follow than a hospital-based practice. But in general, adolescent medicine tends to start with the preteen age, and you could call that even 10. Mm-hmm. I would say puberty tends to be, like early signs of puberty tends to be a sign that maybe we're ready. And then true adolescent medicine, the subspecialty in most hospital-based practices, goes up to either 21 or 25. It sort of differs a lot of times in the hospital. And I joke because in my practice specifically is called Tribeca Adolescent and Young Adult Medicine, because just because someone suddenly magically turns 21 or 25 does not mean that their brain matures to the way that they stop engaging in risk-taking behaviors, or that their puberty happens to be fully finished, or whatever it may be. And so my age has pushed up and up over the years that my practice has been open. And originally I capped at 30, so I saw patients all through their 20s, and then I inched it up to 35 when my patients were getting older, and now I actually will take patients up through 40. Typically the patients that I'm seeing are really in that young adult profile of risk-taking behaviors or have active eating disorders. And unfortunately, the care that specializes in a lot of what I do in the internal medicine world, adult world, is very difficult to come by. So it's not just that the pediatricians are limited, the internists are limited too. So my practice model and the age group that I serve and the issues specifically that I work on are very specific to my patients, where the ages themselves are a little more flexible.
Right. So maybe for listeners, it's the age of 10 to start thinking about, would an adolescent medicine doctor be appropriate?
Yes.
10 and on. And then you said something about the signs of puberty. And I think of signs of puberty as maybe underarm hair, the breast budding, right? Or I think a change in weight, right? Because a lot of times before puberty, the children start to gain weight more rapidly or hold on to a little bit of weight. And this is where maybe the parent gets nervous. And we see a lot of kids coming in from the endocrinologist that, the kid is maybe 9 or 10 or 11, their weight has, skyrocketed, or that they're holding a lot of weight in their belly. And some of that's just natural and necessary because they're getting ready for puberty. So, can you just speak a little bit more to that? And maybe if parents see that, again, the benefit of going to even the adolescent medicine doctor is that you may be privy to or have more time and access to understanding the individual, and is there an eating disorder about to bud, or if we restrict them, will that cause an eating disorder?
It's a great question. I think that one thing that in our training and just our awareness of eating disorders and just our experience of working with patients day in and day out with eating disorders, I think when I approach a patient, I am a new patient specifically, I am really looking at the whole picture. I am looking at the data in front of me, and I always say my job is so much easier than the therapist job in certain ways because I have the data. I have numbers, I have lab results, I have growth curves, I have the vital signs that I take in the office. Those are extremely helpful, but they're not it. And if a physician is only looking at the data, that's a very limited view. Then I am looking at my conversation with the patient. I am having a really, really detailed conversation around food habits, food beliefs, about weight, about body, about how they feel in their body, about friends and who they spend their time with, and family members and what they eat and what just the eating culture is like. We really get into this a lot of times. And I will definitely say that conversation might be guided by the data. So I might see a huge jump in a growth curve, or I might see a big plummet in a growth curve, which that's definitely going to set us a flag, more so than a jump, by the way. And that will really lead to a conversation. And then I will have a conversation with parents, depending on the age of the patient, for even more information. I can give you a perfect example of a patient I just had this week that I think will, it's perfect for the conversation. I had an 18-year-old. She is a wonderful kid. She is one of those highly impressive, highly motivated, the president of 3 organizations. A
perfectionist.
She's, she's straight A's. She's going to an Ivy League school next year. She's an awesome kid, very, very enjoyable when she comes into the office, and truly healthy. She's really a primary care kid. Her parents brought her to me because she turned, I think I've been seeing her since she was 13 maybe, and it worked out well. But I really just do primary care for her. But in every single visit, since she's been, a little munchkin to now an 18-year-old, we've talked about all of it, like sex, drugs, and rock and roll, and then really we get into eating and family dynamics and all of it. Like I said, really good kid, healthy, not really any red flags over the years. And she has been on this growth curve. And she's been a very normal eater, and the family are really pretty, well-balanced eaters. We talk about their diet culture at home, and it's really very healthy. Diet culture I just used in the wrong way. I meant they're
their food culture.
Their food culture. Yes, yes,
right? Like
yes.
how do they speak about health and how do they speak about food? And
Hey, maybe we're
self-care?
reframing what diet culture really should be all about, right?
And my thing is, diet shouldn't be the bad word anyway, because diet actually is about how do you nourish on a daily basis. Diet has been basically that the word of diet has been interpreted or really forged into restriction.
Yes.
But that was not the original definition. If you look up in Webster's, and I mentioned this in many of my books, right? That
you're a dietitian.
Right. Like that's my
exactly.
Our job, our title has the word diet in it.
Yeah.
So there's nothing wrong with what your daily diet is.
Right.
If you're eating enough and adequately, and again, when you approach the diet, you're looking at a holistic, approach to thinking of how do you feed this person and help them to understand how to feed themselves.
Right.
So go ahead and use diet here. We don't think of it, in the restrictive way. I think we all need to be sensitive to nutrition, right? And taking in adequate nutrition is your diet.
Right.
It's what you take in on a daily basis. So I think we know what you're talking about. I hope the listeners know what you're talking about. But of course we do have to listen for or ask questions about the food culture in the home and say, or be curious about whether or not, are carbs allowed? Are the parents following a certain restrictive intake, right? Because those could potentially affect the adolescent because they're prime for being sensitive to the parents' behaviors and even beliefs around food.
Yep. Yeah, it's so funny. I think just going back to the question of how I'm different or how my field is different, I mean, just even terms and how we speak about things, whether it's how we speak about the body, how we speak about food, how we speak about, I think in my world of adolescent and young adult medicine, we really are very aware of language. I mean, that extends well beyond just food and culture. I mean, whether it's talking about gender or whether we're very kind of in the know. I mean, we have to be. We have to know the cool terms that the young kids are saying. We need to know the really not PC terms of the day because that's what we do all day. And so, but when it comes to food and body, I think we're very sensitive in a different way than, many of the kids that will come in, and I will hear stories of them being admonished by their pediatrician. I mean, I can't even tell you the stories that it's still to this day I'm hearing about a kid crossed one growth curve and the pediatrician just admonished them for eating ice cream after school with their friends, and the kid was 8 and went to ice cream after school with their friends. And it's the whole picture and how you use your language to approach what might be a concerning trend as a doctor that you're seeing, and you don't want to not approach it, or it might not be, and you have to be able to flesh that out appropriately. So okay, so let me go back to this patient. So I take this patient's weight at the end, and I made a mistake, and I will admit that. I didn't, in the visit, we had looked at all the different things, and then I hadn't really looked at the weight, the full weight trend over the years. We had gotten into a long conversation about some other things, and I had taken the vital signs, and honestly, we did a whole food nutrition talk. She's, like I said, really well balanced, all the things, and she basically left my office. I talked to her alone. I talked to her mom at one point, but she's over 18, so really it was much less about the mom, although the mom was there, and left. I went back to my computer a few hours later, and I was doing my notes, and I was looking at her growth. I took a look at her growth curve, and I went, oh my God, she has lost 17 pounds this past year. Wow. And I had seen her for 1 or 2 visits halfway through the year, and she's, like I said, she's not like a frequent flyer. She came in once for strep and came in once for a rash, and the weight hadn't been anything concerning really at that point, and then she had not been in my office for about 8 months. And I went, whoa, and she'd already left my office. And I'm like, oh my God, okay, what is going on here? I did a full nutrition intake, everything seemed normal. I asked about body image, One difference was that she was exercising more. This is a kid who really had never played sports, never been into it, and she started to enjoy some workout classes, but it really didn't seem excessive. So I said, okay, I need to make some phone calls. So I called her. I asked her, can we speak? And then we had another talk later in the day. And I said, I realized that it wasn't until after the fact that I looked back at your growth chart and we didn't really speak about the numbers as much as we spoke about the habits. And to that point, your eating habits sound great, but is there anything I'm missing here? It's really striking that you've always been along a very normal curve and suddenly 17 pounds down. What's up? And she said, it really wasn't anything I noticed. It wasn't intentional. It sort of happened gradually across the year. I have noticed. She said, I think that I've started exercising more, and she really didn't have a great answer. And I was very forthcoming. I said, look, as a doctor, this is something that really raises some red flags, but you seem really well around the way we're talking. But I'm going to have you come back in. I'm going to have you come back in 1 month because I just want to make sure that this isn't continuing. By the way, she's still at a very, very healthy body size. It's just not the same percentile she had always been on now.
Mm-hmm.
And I said, I'm going to have you come back in 1 month. I'm not sounding any alarm bells, but and I said, would you mind if I speak to your mom about this? She's over 18. I said, I just want to make sure that she agrees that there's nothing she's noticing. And the patient said, sure, no problem. Here's where I'm going to blow your mind. Are you ready for this? Called the mom, and she said, it's so funny. I don't really know why so-and-so, my daughter, isn't telling you the whole story. And I said, uh-oh, what am I missing here? Oh my goodness. And I was just like kicking myself that this hadn't come up in person. Not that they had brought it up, but, and she said, here we go, guys, you ready? She said, my husband and I, so the mother and the father, have been on a GLP-1 this year. We felt like it was something we wanted to do for ourselves. And because of that, our eating habits in the home have really changed. When we go out to dinner as a family, we've stopped ordering appetizers a lot of times. We haven't been hungry for dessert. And our kids, and there's 2 kids in the family, just sort of eat the way we eat in the home. And since our whole home has changed some of our eating habits, they are eating just less or different foods than they used to. And I will say the mother was very much like, this is actually something we've talked about in the home, where we've brought it up, we've explained it, we talk about why we've made this decision and why we want our kids to keep eating wholesomely, and the kids are both very healthy, it seems. And she also mentioned the exercise. She said, this is something that finally at this age of 18, my daughter's taken an interest in. And I said, listen, I'm hearing all of this. Thank you for sharing. I appreciate the honesty. And there's not necessarily a judgment here, but I am going to say, this is something I'm now suddenly aware of. I want to see your daughter again in 1 month. I want you to keep a lookout before she goes to college. I want to make sure this weight loss trend is not something that's continuing. And that was how we left it. I think I made myself clear that, like, we are all now on the lookout here. But, I'm not necessarily freaking out, but I'm very aware.
Would you perhaps refer to a dietitian who specializes in eating disorders at this point, just to have second eyes on the individual and see if in that more like holistic and or therapeutic food environment that they could feel comfortable to open up and speak to what else is going on, or even potentially even a therapist at this time, knowing that there's a transition happening, a transition with the food in the family, a transition with, going from a high schooler to a college, because I think Shannon and I see often that, because 17 pounds, honestly, even if a person is, like if that's their normal percentile, like in my experience, if they're 17 pounds,
It's a lot.
like that's pretty significant. I'm thinking they're dropping at least 1 to 2 percentiles on the growth chart, right? And, I think also as a dietitian, who works with multiple ages, and as a parent of a 19-year-old and a 17-year-old, it is so easy to miss things.
Oh, yeah.
And, I feel that, you have to ask these young adults in multiple ways and have multiple people asking the questions to really find what is their truth. And a lot of these adolescents aren't even aware, right, until you're really exploring it. But I think that there's this very small window that we may have into preventing this from spiraling into something bigger. And so
I could not agree with you more, Laura. I could not agree more. It's interesting. So the patient has a therapist. The patient has a therapist really, which actually took quite a lot of convincing from me over the years, really only because of this very perfectionistic tendency. I mean, in a lot of ways, we're talking about a patient who's very set up for this, right?
They're completely set up because they literally, when you were speaking to how perfect, right, they are, right, Ivy League, like all of these, right, and in a transition. So anytime our child or adolescent or young adult is in a transition, this is a time to be mindful that, again, an eating disorder could develop, substance disorder could develop, and or, again, I don't know, you probably have a longer list than I do, of what happens in transitions at this age range. But
so I'm, as I do in my practice all the time, I would say my threshold for referring patients to dietitians and or therapists is very low. So this is a patient who, for years, I've wanted to see a therapist, really not necessarily because of anything in particular. In fact, this is a patient who doesn't really endorse much anxiety. She's fairly just kind of go with the flow, although I think that's more of a outward portrayal of, that's just my opinion, but I'm not, but she does speak with a therapist now. And I said to them, I've always been in touch with your therapist. I'm just going to give your therapist a call.
Great. Love it. Great. And I love that you have the ability to do that, right? That
my gosh.
You have like that, the adolescent has signed, because remember, when someone is 18 and over, parents don't have the ability to just call the doctor and share any information or to get information, right?
I even had to ask her permission to even have this conversation with her mom. Which I'm actually wondering, looking back, I mean, the situation was, let me tell you, when I saw that and realized that we hadn't actually gotten into it in the visit, oh my God, my heart sank. Like, everyone makes mistakes, but I was like, oh God, I have to be able to review this. And luckily I did. But I wonder if one of the reasons that maybe hadn't come up in the visit was, it's all the things. You start thinking about all the things. And so believe me, I'm on high alert. But I asked for permission to speak with the mom, and she let me, which is great. And just sort of putting the mom on alert is part of it. But I do sort of have on in fact, if you read my note, it was come back in 1 month. If anything has continued, if there are any more concerns, we have about 2.5 months till college, dietitian referral for, whether it's reviewing meals. We were going to get into it. We're going to really not let this. I'm giving them the 1 month to come back and show me that things are stable. And if they're not, then we dive in.
When we're thinking, I was thinking, because we're thinking of, okay, we saw this drop in the weight, and this might not be just for this patient specifically, but what are some of the subtle signs that providers and also parents might be missing, because it's easy to miss things? What are some things they should maybe be on the lookout for before things escalate?
Yeah, because I would say this is one of the least subtle things.
Yeah,
absolutely. I mean, being on the lookout is having the time and the ability to really have those discussions that I was talking about. I would say one of the things that I think I really ask a lot of is body image questions. How do you feel about your body? How do you feel when you get dressed? How do you feel how do you feel when you're going out to hang out with someone after school? How do and sort of reading the answers there and seeing that side of things, because even if something's not necessarily yet being reflected in behaviors around food or exercise, there might be a lot of the inner negativity, and that's where I think it starts. I wish for everyone to feel really great in their skin and like themselves and confidence, and especially in the adolescent age group where your body is changing rapidly, it's changing in ways that are very foreign to you. You look drastically different. 3 years prior, you looked like a completely different person, and it's really hard and you might look at like a completely different per age than your peers. Everyone changes at such different times, and so I think just finding out how my patients feel in their body, and it's not always weight related. It could be about their skin, right? We talk about skin constantly, acne and just skin changes. We talk about hair everywhere on the body. I mean, I really try and be open with my patients about how they feel in their own skin.
Right. I think the other thing is, also, I just remember this from growing up too, it's like the size of everybody's private parts, right? Right. Like, again, like, are they like flat? Are they, made fun of or, viewed by the, the opposite sex because of, again, something that has been maybe made aware of by a peer. I was just reading this morning, something, and actually I believe I sent it to both you and Shannon, but really speaking to there are these apps now that really focus on kids' appearance, or even perhaps will, people might take pictures of somebody eating lunch and then post it to these apps, and then they make fun of somebody, and it could be just anybody. And if you get posted on that, now you're going to be self-conscious about eating your lunch and not want to eat lunch at school because people are taking pictures of you and posting pictures of you eating, right? Or I'm very privy to how a lot of individuals, my clients share this, how they, if someone goes out on a date and, they basically it's, when the individual comes back home and they share it with their friends, or maybe they Snapchat something, then that becomes everybody's date, right? And so, the person that they went out with now, like, again, do they know whether or not they're a good kisser? What their breath smell like? They know all these intimate details through these apps and through Snapchat and things like that. And I'm just like, oh my goodness, it's just, nothing is private. It's all open. And then these kids are subjected, or adolescents are subjected to so much, I think, negative feedback, right? So, I mean, I think that's other things those are other questions we need to start asking about, like, what social media are you on? And, have you ever been targeted, or do you have your picture taken, or like, what else is going on? Because there are so many things that I think, again, and I have a 17-year-old and a 19-year-old, and I see so many adolescents. So I'm learning every day, and I'm just like, OMG. I feel bad for these kids because they are targeted like no other.
It's funny, I was thinking about this at the beginning of the talk, but it's coming up again now. You ask about the difference in my visit than a pediatrician's visit, let's say. Now, when you're in medical school and you learn about taking care of teenagers, taking care of an adolescent, you learn something called a HEADS exam. HEADDSS. There's a few versions of the D's and the S's, but this is like the psychosocial history that you're supposed to take for an adolescent. And I remember I'm going to tell you what it all stands for, but I just remember being in my pediatrics residency, and I always loved adolescents. This is what I wanted to do. But in the world of pediatrics, you are seeing so many patients, and you have so little time. You have a panel of kids coming in and out of your office. You've got screaming babies. It's really, really, really exhausting. And you're supposed to sit down with an adolescent and go through this HEADS exam in the middle of your visit. And maybe you're allotted 15 minutes for a follow-up. And the HEADS exam is home life, education, activities, The D can be various things: dating, it can be depression or mood, it can be drugs, and then the S can be substance use, like you can kind of, and sex. And there's a proposal now, and I really do this, actually, I truly do, adding an S in for social media use. You can add the S in for safety, just like to talk about, I mean, literally you're supposed to talk about everything from do you wear seatbelts in your car, to bike helmets when you ride your bike, to, are you smoking cigarettes? So to get through a heads exam, just to ask all those questions. If one of the answers is anything concerning, you want to delve into that. How do you get through all of them? And most of these adolescents have a lot going on. You're going to get to the substance use part and say, oh, have you ever, vaped? And they're going to say, oh, yeah, I vape every day. Okay. All right. We got to talk about that. So it's hard. Now, in pediatrics, when you're seeing a ton of patients, you simply don't have the bandwidth. You simply do not. And that's where one of the problems is. For my patients, I reserve way longer amounts of time for each of my visits than if you were in a pediatrics practice.
Could you share with us how long on average do you see an individual patient, maybe for their initial and then for a follow-up?
All right, so let me give you a little bit of context about my practice model. It's very unique, and I just want to say that I am incredibly lucky to be able to practice this way, and I know that. A few years ago, I made the decision to not take commercial insurance. Because commercial insurance is so limiting for how they reimburse physicians for adolescent health care. There is just simply, it's almost impossible to take good care of adolescents and young adults in that model. So without the constraints from commercial insurances, I was able to change all my visit lengths. So I reserve 2.5 hours for an initial visit.
Right. How beautiful is that? You get to spend 2.5 hours.
It's
oh my God.
Unheard of. It's unheard of. And, and I don't necessarily take 2.5 hours. It very much depends. But that allows me, if I have a patient under 18, I can interview their parents. I often will see the patient alone. Well, I always will see the patient alone, no matter what the age. But I will often see them alone, then the parent alone, then them together. It sort of just depends on, I can be so flexible. I have so much time. I can really spend a long time on the exam. Laura, you brought up body parts and what's normal. The number of times patients say, is that normal? And I'll say, let me show you. Let's talk about it. Let's examine, So I have so much time. That is the first visit. And I always say to the poor patients who are stuck with me for 2.5 hours, I'm always like, I promise you no visit will ever be this long. And then I'm so individualized. So if a patient needs to come back for an hour, they come back for an hour. If a patient needs to pop in for 15, 20 minutes, they pop in for 50. It's very much very patient dependent.
And I want to also point out that, this also allows you to speak with someone like Shannon and or myself. Very often when we all have clients, whether or not they have an eating disorder, right? Because it could be a thyroid issue, it could be a GI issue, but it gives us the opportunity to collaborate, right? So often we have team meetings where, you're meeting with the adolescent specialist and or the therapist, psychiatrist, and even the parents, right? So that there's this dialogue and everyone is on the same page supporting the individual in this very challenging time and obviously culture. So, we too don't take insurance because insurance would not reimburse us, right, sufficiently to even pay for New York City rent, A. And it doesn't afford you the time or the ability to dig deeper.
Correct.
Than just something that's on the surface. And everyone is so complex and everything needs to be so individualized that you can't cookie cutter a human.
No, you really can't. And it's really unfortunate that that's the way that our healthcare system has gone. I mean, it's a problem all over the world in different, we have an international adolescent medicine committees, and we have conferences that have adolescent doctors from all over the world, and it's really fascinating. But it's a universal problem, is the amount of time we have as physicians to spend with our patients. There's just never enough.
Right.
And then all the background time of care collaboration with professionals. It's so important.
Mm-hmm.
And it takes up a lot of time.
Yeah. I mean, I do, I have to say, like, I am grateful for our insurance, right? But I think for different specialties or for different physicians, again, having the ability to work outside of the box is super helpful. But I also am grateful for something like, I went through chemotherapy, right? And I was very grateful to have insurance to obviously pay for something like that. But, I do wish that we all had, or that everyone had as much time, as we, the three of us, have with our clients and or patients.
Yeah.
Thanks so much for listening to part 1 of our conversation with Dr. Risa Fridy on adolescent medicine, what it is, and what parents and clinicians need to know. Stay tuned for part 2, where we will dive into social media, looks maxing, eating disorders in adolescents, and how to raise resilient teens. If you're enjoying the show, please be sure to follow along for more and leave us a comment letting us know what you'd like to hear more of. You can follow us on Instagram at Eat Kale and Cupcakes and learn more about our work at lauracipullo.com, as well as in the show notes below. Until next time.